co-leads and serving currently as the director of the Community for Global Health Equity. And I'm thrilled to see all of you here for our first Global Health Dialogue of the year, this academic year. So I welcome all the new students and all of you who haven't come to our dialogues before, and definitely all of our returnees who've been to dialogues before and are still willing to come back and spend time with us. I know there are a number of new faculty new to the university, so it's wonderful to see you. And we look forward to getting to know you over the course of this year. I wanted to introduce Corey Smith to those of you who don't know him. Corey is a faculty member in architecture and associate dean, and is also one of the co-leads. Dr. Samita Raja, who is from Urban and Regional Planning, and Dr. Lee Lin from Industrial and Systems Engineering are the other two co-leads of this Community for Global Health Equity. As you may know, we're a university-wide entity, and we serve as a resource to promote multidisciplinary scholarship, education, and collaboration with partner organizations to address health equity concerns in low and middle income countries, as well as among the refugee population here in Buffalo. So we had a debate amongst our administrative team about whether we should have dialogues once a month or once a week. And in the interest of kind of keeping these conversations going and having a pretty regular form, we have decided to keep them once a week. And I hope you'll be coming back at this time regularly. Just despite saying that though, Monday we're having our annual meeting, and so in the interest of not taxing people's time, we are not having dialogues for the next 2 weeks, but then we'll be starting back up again in the last week of September. There's always food. We like to know if you're coming, so that we can make sure there's always a little bit of food for everyone, if anybody wants. This first dialogue of the semester is particularly special to me because I'm so happy to introduce Dr. Steve Luby. Steve is a dear friend, colleague, and mentor. He was my supervisor when I first left residency and went to CDC, to the Epidemic Intelligence Service. He was my supervisor assigned. We were matched. I was matched to the enteric diseases group, and he was my assigned supervisor, and we basically have been working together ever since. So now more as colleagues and collaborators, although when I get his feedback on my manuscript, I go back to sometimes feeling like a trainee. And so that cycle of iteration never ends. But that's a good thing, and as I have learned from him so often over the years, that's why we work together with people that we learn from and grow with. And so that's been a really terrific cycle. So Dr. Luby is here to give the first annual Richard Lee Global Health Lecture. Some of you may know Dick from his work in the medical school, in medical anthropology, as well as some of the work he did with medical students, taking them to places like China and Tibet and elsewhere. Dick passed away really unexpectedly a few years ago, and that was a big loss to our community. But one of the things that the School of Public Health and Health Professions wanted to do with this newly funded annual lecture series was to bring to the campus a really smart, strong thinker who's thinking broadly about the big challenges of global health. And so when the task was given to me to try to come up with names, of course, this one came immediately to mind. Because something to think about for our work in the Community for Global Health Equity is that Steve exemplifies someone who thinks about problems as not being one-dimensional or even two-dimensional, but all the many complexities that those problems carry with them. And that's what makes them hard to solve, but also really compelling and intellectually stimulating. And so by nature, a lot of your work over the years, I know, has involved inputs of so many different disciplines. So we wanted to take the opportunity today to have Steve reflect on one stream of work that he's done over the last decade or so, of extending his work to a disease of pandemic potential, Nipah virus, and to think about that through the lens of multidisciplinary work so that we can all reflect on that in this community of excellence. So what did you decide? Dialogue?
Yeah.
Or wait till the end?
I'll probably ask them some questions. They can ask me questions. We can stop at any point. At some point, if they just want to get up and have food, that's okay too. academic year 2016. Sometimes in our career, we seek problems out and we say, I'm really interested in that, I'm going to go work on that. Other times, problems come to us. For me and Nipah virus, Nipah came to me. I remember hearing about an outbreak in Malaysia. I was working with poverty and diarrheal diseases, listened to the lecture at CDC, said, whew, bad disease, and then went back. A few years later, I took the position as the Centers for Disease Control country director in Bangladesh. And it turns out that Bangladesh had a problem with Nipah virus. So I arrived there in September. On the 11th of January, we heard a report. Government health workers reported that 8 previously healthy people had died in one particular area, Bashal subdistrict, within a 1-week period. Well, at CDC, we like doing outbreak investigations. So this is the kind of thing, you said 8 people previously healthy, shouldn't happen, what's going on? It took a while to develop enough trust with government colleagues, but then we decided to go up together and try to figure out what was going on. Eventually, we came up with a case definition that included fever and mental status change, and identified 12 people who met this case definition, not just the 8 first reported. All of them had fever, that was part of the case definition. A third of them had seizures, 75% were unconscious. Most notably, 92% of them died. 11 of 12 died, and the median time from this first symptom to death was 4 days. So at that point, we didn't know what we were working with, but I did know we had a serious problem. So we're epidemiologists. I realize not everybody in this audience is. Epidemiologists are not the brightest group of people. So we just sort of do things sort of simple. So we said, well, here's the person. How can we figure out the place? So we looked at where this occurred in the place. So this is just a map, and you can see physically where these cases where you can't see because of this kind of screen that doesn't show a laser pointer. But you can see that we had the cases were incredibly clumped. They were clustered geographically. And this is all just over a 2-kilometer area. So really tightly clustered geographically. Then we also look at time. So if we look at these cases over time, we also see remarkable clustering. These cases occurred over a very short period of time, suggesting a common source potentially caused it. Also, we heard about the outbreak after it was largely done. And indeed, since we heard about it so late, we couldn't collect blood on everybody that we would like to collect blood. The first case was the survivor, so we were able to get blood from her. This person was still alive when we went out in the late case, so we had 3 blood samples. We sent those 3, it took us a couple months to get them sent to CDC and get them run, but basically there was antibodies against Nipah virus on 2 of the 3. The one that was antibody negative died, we collected sera 2 days after symptom onset. And this has been well described with Nipah, that the disease progresses so quickly that about 1/3 of the people who have the disease die before developing antibodies. So this then created a puzzle. We know from prior studies that Nipah virus is a bat virus. And if you look in Bangladesh, there is a particular fruit bat, Pteropus medius, that has a wingspan of about this large. They're large animals, but it raises the question, how does a bat virus get into people? So we did know the outbreak was caused by Nipah, but the question was, how? So this is actually a pretty standard problem in epidemiology. We have a disease, and we want to know what exposures lead to disease. So what exposure is going to get us there, and we'll tend to frame this in terms of a quantifiable study question. So we think what exposures were more common among people with disease, and then compare to people without disease, and see if that can give us a clue as to what exposures might be relevant for transmission. So we did a case control study. That is, we compare cases, people who had the disease, all these 12 people who met the case definition. We compare their exposures to controls. For controls, we took the next closest house to the case, and we found the person closest in age to the case. Now, since 11 of the 12 cases had died, we had to use proxies to ask about exposures. So when we put this together in tables, and this is the kinds of things that epidemiologists get very excited about. We actually have tables we can analyze, we can have statistics, we can compare exposures in cases and controls. So like one of the exposures we were worried about was climbing trees. And an earlier study had suggested that you could go, well, yeah, you could climb trees, you might get close to these bats, you might get in the bat here. And if you look at it, you'll see, sure enough, 25% of cases climb trees, yes. People who had Nipah, they had this exposure, but the beauty of a case control study is we can say, oh yeah, but so did people who didn't climb trees. So unlike just a journal article or a presidential candidate who can just talk about the exposures that cases have, epidemiologists like to compare cases and controls. And so we say, look, there's actually no difference, so there's no reason for us to believe that's a risk factor. And we generate lots of these tables, lots and lots of tables, looking at what people ate, whether they had contact with a sick person, pages and pages and pages of these tables with lots of null values. In the end, though, on this outbreak, there was a single exposure that was different between cases and controls. Cases, it turned out, were 7 times more likely to report drinking raw date palm sap than controls. And that was such a strong signal, it was very unlikely that chance was an explanation for that exposure. So, I grew up in Nebraska. I'd never heard of raw date palm sap. So my first question was, what is raw date palm sap, and how do we think about it? So at this point, it's not an epidemiology undertaking anymore. We had our anthropologists go out and try to learn more about this exposure, raw date palm sap. And what we learned was that raw date palm sap was a little bit like maple syrup. They collect it during the winter time. You cut a tap into the tree, and you place these clay pots on the tree. They're tied up with the rope. And then during the winter night, the sap rises, and it drips out of the shaved part of the bark into the clay pot. Most of that is boiled into a molasses. And they've been doing this for centuries in South Asia. In fact, the tree is referred to as the sugar date palm tree. But some of the sap is sold fresh. And people in Bangladesh love fresh date palm sap. I mean, it's a delicacy. And some villagers did notice sometimes, I think, the bats visited the trees at night. As we talked to the date palm sap distributors, one of the fatal cases was the son of a date palm sap collector, and this boy loved date palm sap. He drank it every day. The collectors had heard bats in the trees the night before, and they even found some bat poop in the pots, which means you can't drink it fresh. But several days prior to the outbreak, he collected some sap and sent it to neighbors as a gift, his relatives in a nearby homestead. And 3 of the cases occurred in that family. So at this point, the epidemiologist felt pretty good, and we actually could write the article that said, look, we see an association, we saw an outbreak, the outbreak was Nipah, We saw an association between this exposure and the outcome, and we even have a story that sounds biologically plausible. The truth is, when that went out to a global scientific audience, there was a lot of skepticism. They said, oh, you epidemiologists, how many tables did you run? How many exposure? You have a statistical association. Have you found the virus in the sap? And so I would say, well, if you think about, by the time we heard about the outbreak, if we went around, we think the transmission event would have had to occur a month or so before. We would not expect to find, well, then you didn't find it, then how can you just have a statistical association? This is only a statistical association. So we started to think seriously about what's the evidence base that allows us to say maybe this isn't just a statistical association. So one line of evidence is that viruses bats, the Pteropus bats, shed these viruses in their saliva. So both Pteropus lyli in Thailand and in Bangladesh, not commonly, less than 1% of the time, but occasionally shed at least the RNA. So evidence that the virus is there. And Saladin Khan was a veterinarian on the team, and he got so frustrated by this critique, he said, we'll never get it out of sap, because you could run around and collect sap, but there are millions of pots everywhere, and we only get one outbreak a year. It's never going to work. So he said, let's look at it differently. Let's see what the animals are doing. So his idea was to put up wildlife cameras that had motion detectors on them, infrared, and say, let's see what the bats are doing. And it was, you could actually see it pretty clearly. And here is a video piece together of a bat coming in. And you can see that it's licking the stream. That is the sap stream that's shedding. Kind of looking at the camera a few times, mugging for the camera, and then...
That's it.
That's it. That was really the response. Saladin was absolutely right. Once people saw this, they're, oh, you're kidding. So this is the implicated vehicle. There were 92% of visits. Bats licked the sap. They stayed at a median of 1.9. It actually, this additional evidence, which I really want to emphasize, was not epidemiological evidence. This was animal behavior evidence. But how, when we were trying to construct a persuasive narrative, we had to step out of our discipline. And it was really microbiologists who were saying, oh, you don't really have evidence. So then we also, Emmy DeWitt from the Rocky Mountain Laboratory did some animal studies. She took 8 hamsters that had drinking water replaced with artificial date palm sap that was spiked with Nipah virus for 2 days. And 2 of the hamsters died, both from Nipah, and 2 more showed seroconversion. So she concluded hamsters could become infected with Nipah virus by drinking contaminated sap. We also then, after we had the insight from the Tongile outbreak that this could be a vehicle, we started to ask about it in subsequent outbreaks. And not in all outbreaks, there are other ways Nipah can be transmitted, but in 3 subsequent outbreaks, again, a very strong signal that people who drank, cases were much more likely to report drinking raw date palm sap than controls. So, we no longer call this a correlation. We say there is a causal relationship between exposure to raw date palm sap and infection with human infection with Nipah virus. The evidence is bats shed the virus, bats contaminate sap, the virus survives in sap, animals that drink sap become infected. I didn't present the evidence there, but there have been studies done on that. Spillovers are only identified during sap harvesting season, and people with Nipah were more likely to report sap. So we have a zoonotic disease, a disease that, a virus that lives in bats, and evidence that it goes to humans. And if that were the end of the story, we might say, well, that's kind of bizarre or interesting in a weird way, but Pavni probably wouldn't want me to talk any more about it. But there's another dimension to this virus, and I want to take us to another outbreak. And this is the Faripur outbreak from 2004 in Bangladesh. So the first case there, labeled A, was a person who lived in Malikpur village, and he loved date palm sap. He drank a lot of date palm sap, and he got sick. Now when you get sick in Bangladesh, it's different than when you get sick in Buffalo. When you get sick in Buffalo, you go to the hospital. When you get sick in Bangladesh, it's your family who takes care of you. Families really provide the direct care, not healthcare staff. And this is really rooted in the idea of emotional support. There's a strong cultural expectation to stay close to people, to provide hands-on care with direct contact with the patient's body fluids. There's a desire to be close during that time, and when people are dying, to whisper comfort, Quranic verses, to really be very close at that time. And it's family members and religious leaders who prepare and cleanse the body, particularly the offices, for burial. So in 2004 in Faripur, this first case in Malikpur was cared for by 4 people. By his mother, his son, an aunt, and a friend. And what happened then was 2 weeks later, those 4 came down with a similar illness. Now, case B there was his aunt. His aunt was a member of an unusual religious sect. This was a sect that practiced a different version of Islam, that had men and women praying together, and that was led by a particular religious leader. So when she became very ill, he came and ministered to her as she was dying. And 2 weeks later, he came down with a similar illness. Well, his illness was a crisis to his religious community. And so all of his religious followers came to be with him as he was ill and as he was dying. And 2 weeks later, 23 of them came down with illness, and then the people who cared for them. So over the course of 5 generations of transmission, there were 36 cases, 27 deaths. So 75% of people died in clearly what was a person-to-person transmission outbreak. We might have gotten started here with a bad infection, but this was a person-to-person transmitted outbreak. So when infectious disease epidemiologists think about person-to-person transmission, we have a number called R0, the basic reproductive number. That's the average number of cases that one infected person transmits to. So Nipah, on average, transmits to 0.5 people. That's why we don't have Nipah in Buffalo, because we get these chains of transmission, these stuttering chains of transmission in Bangladesh that stop. And we see these types of outbreaks that recur, but they keep stopping because the R0 is not efficiently enough transmitted, because it's a bad virus, it's not a human virus. However, if a virus changes, if a zoonotic pathogen increases its capacity for person-to-person transmission, if the R0 becomes greater than 1, then a new pandemic can emerge. And the particular concern that we infectious disease epidemiologists have is that each time a person is infected, that virus or that agent is in an environment that is selecting for being in a human and surviving in a human. So there is a risk for adaptation to human transmission. And indeed, if we consider these RNA viruses have the highest rate of mutation of any living thing. I mean, they're just wild. And so consider zoonotic RNA viral pathogens that demonstrate person-to-person transmission. These are influenzas like the avian influenzas, SARS, MERS, Ebola, Nipah. The concern here is that all these viruses are one competency away from a global pandemic. So we might think, wait a minute, Nipah is just a problem over there in Bangladesh, 10 or 20 cases a year, but maybe not. And you might say, well, look, Steve, you're a fearmonger, you're trying to get money for your research program. How serious of a problem can this be? Well, let's look at human history. If we go back at human history and say, what are the most devastating infections in human history? AIDS would rank pretty high. HIV. HIV was unknown to humanity a century ago. It's a chimpanzee virus. It's a chimpanzee virus that has been adapted to humans. It has gone from a simian immunodeficiency virus to a human immunodeficiency virus. Similarly, measles. Measles was unknown in ancient times. Did not emerge until the 12th century, came from a cattle virus, rinderpest. And we look, indeed, if we look at what has killed people from infectious disease through the centuries, it's been zoonotic diseases. So, we might want to stop Nipah transmission, even though it only affects 10 or 20 people a year, because of the pandemic risk it represents. So I thought this was a good idea. I said, okay, well, how are we going to stop it? Well, we talked to some date palm collectors up in Rajshahi in the north, and they said, what we do is we put lime around it, and the bats don't like lime, so they don't land in the tree, and the sap becomes more clear. It's a better idea. The date palm collectors farther south had never heard of that. Thought, why don't we try this? So they were a little concerned it was washed off and required 30 to 50 seconds to put on. One neighbor opined, you're mad, your father is mad, those who sent you are mad. And I take a little offense to this. Your bosses are mad. Like, I'm all for qualitative work, but this is what they bring back to me. This method is not going to work against bats. So, nevertheless, Saladin went up, he set up his infrared cameras, and we found that bats came and visited all the time, and lime didn't seem to bother them at all.
So they were right.
They were right. They were right. They were 100% right. And this is one of the things that's so remarkable about what anthropologists can teach us is, no, what do the people understand? And you're absolutely right. There's just an enormous amount of empiricism that supports those kinds of observations, right? So, so what do we do when a pilot fails? Try again.
Find other viable solutions.
Yeah. Yeah, I think that's right. I mean, you either revise, you say, well, maybe we should put more lime on. Maybe we should double the concentration of lime. We can, like Whit says here, can we take a different approach? Okay, is there another way we might interrupt? Okay, could we quit and go into medical history or just another discipline or something? I don't know. Those are all different options. But I like Whit's idea of saying plan A didn't work. It's still a good idea to try to interrupt this. Maybe we'll try to do something different. So another idea was to put up a bamboo net. This is a variation on traditional fishing nets. Occasionally had been used by folks if they said that there was a favorite tree that gave really sweet sap that the bats were pooping in or something, but it wasn't widely used. So we said, well, maybe we'll try this. So we started with a small-scale pilot study, anthropologists led, saying, could this even be acceptable if we did it? And we found that people could basically had old dry bamboo laying around. It was similar to weaving fishing nets, so they knew how to do it. Materials didn't cost very much, though they did take time to make them. And it would take extra time to put them in the trees. So we encouraged them to do it, and this is the kind of things they said after they had tried this. After applying this method, I have not got bat feces into sap, though I used to get bat feces before. And that's helpful because that means you can sell it fresh. This is the first time the owner of the date palm sap trees took sap from me for raw consumption, as the sap was better in quality. So thinking, oh, we might have an economic incentive. When people come to know that I use bamboo nets, they'll be more interested to buy molasses, which I make. So if we're not consistent with the local incentives, we'll never get there. So we felt this was important. Then we said, well, is it actually going to work, or is it going to be about as effective as the line? So we did an efficacy trial. Would the nets keep the bats out of the sap? So we took 120 sap-producing trees, and we randomly assigned them. We did a randomized control trial of trees. 60 were enrolled as control trees, and they were matched on a height and shading pattern. And then we used different types of materials to make the skirts. Jute, deutsche, and bamboo, those are local plants, or even just polyethylene bags. And then we again set up the cameras and said, are the bats going to get there? So what we found in the trees that you had nothing covering, there were 3,556 bat visits. These bats have figured out this is a nice place to go for a sugary drink in the winter. They visited a lot. On the other hand, if you had a bamboo net up, they could never contact the sap. The same with the others, though. There was a little gap in one of the jute trees. So basically, by putting on a skirt, we could keep the bats out. So the next thing was, okay, can you convert these little pilots into an intervention? So lots of discussion with the government of Bangladesh. They said, we want to just say no. Don't drink sap. You have finally convinced us with your repeated outbreak investigations that sap causes Nipah. Let's just say no. So we have a Just Say No campaign in 348 villages that we use posters, a video documentary, we train local organizations to encourage people to understand that there's a risk to drinking raw date palm sap. But we also, as public health practitioners, know that we can go to somebody who's injecting drugs and say, it's not in your long-term best interest to inject drug in your veins. And you will find, even when you go to medical school, that when you tell people this, they will still inject drugs in your vein, despite your sincerity. And I'm sure you'll be very polite and persuasive. But they'll still do it. So then you might say, well, if you're going to inject drugs, at least use a clean needle and syringe, or at least wash your syringe with bleach. So public health folks, we tend to be pretty comfortable with harm reduction strategies, even when governments are not. So it took us a while to get government to say, okay, you can try an only safe sap intervention, which is, you want to be perfectly safe? Don't drink sap. If you're going to drink sap, make sure it's from a protected source. So I want to show you, okay, so we had that, so this was stood up in 3 districts. This is not a beautiful cluster randomized trial because we had to be, a lot of this was community level intervention. So we had control communities there in Kushtia, some no raw sap, and some only safe sap communities. And I want to show you what the communications team put together for us, to give you an idea of the sophistication of the approach. Go.
জি চাচা
আমার নাম নিজে রস চাইতো তুমি চার দিলে আমাকে
কাঁচা রস খাওয়া যাবে
বাবা উনি ঠিকই কইছে
খেজুরের রস কাঁচা খাওয়া যাবে না
গাছের রসের গাড়ি বাঁধলে
হ্যাঁ
রাতের বেলা বাদুর এসে বসে যেই বাদুরের রোগ আছে সেই বাদুর যদি রসের মুখ দেয় সেই রস খাইলে মারাত্মক রোগ হতে পারে
আপনি ঠিকই করছেন ভাই মারা গেলে বাঁচাইছেন কাইলে তো তুমি একারি রস দিলা কাঁচা খাওয়া দিই
ওইটা তো বানায় ঢাকা রস আমার বানায় ঢাকা খেজুরের রস কাঁচা খাওয়া যায়
বানায় ঢাকা রস মানে
খেজুর গাছের রস ধরার সময় গাছের কাটা অংশ আর হাড়ি বানা দিয়ে ভালোভাবে ঢেকে রাখতে হবে যাতে রসে বাদুর বসতে না পারে বানায় ঢাকা রস থাকে নিরাপদ এই দেখেন এটাকে কয় বানায় ঢাকা রস না
তুমি খালি একটা কাঁচা বানাইছো না
কাঁচা রসটা আপনি এক হাড়ির বেশি খান না
হ্যাঁ রস সিদ্ধ কইরা গুড় পিঠা এসব বানাইলে খাবার নিরাপদ
তাই আর কিরে মা খাবি নি গিয়ে কল বানাই রাখা রস
আমি আরো খাবো আমি আরো খাবো
রাতের বেলা খেজুরের রসকে বাদুরের সাথে এই রস কাছে কাছে মারাত্মক বিপদ হতে পারে এবং পরিবার ও প্রতিবেশীদের মধ্যে কাজ করাতে পারে। নিপাল থেকে বাঁচতে এগুলোর কাঁচা রস খাওয়া নিয়ে তবুও যারা খেতে পারে বানায় কাঁচা রস খায়।
So I think what you can see is this is pretty sophisticated. This was not a couple of public health docs saying, let's take my cell phone and shoot a little bit of video. We had really good communication people thinking a lot about the message and really working a lot to connect with the local community. And we could evaluate the impact. We could look at what people saw in the different intervention components. The public service announcement that I just showed you only was seen by about 10 or 12% of people. But this is who saw it directly. A lot of them talked about it when they went home. And that was particularly aimed at people who had access to TVs, which were men, primarily because they would go to the tea shops. And you can see that by the time we look at whether you are directly or indirectly exposed, we had pretty high reach in these populations. And we look at reported behavior. The no raw sap group actually said only 15% of them drank unprotected sap. So they actually had the lowest level of sap protection of drinking unsafe sap. On the other hand, people who said you could get sap if it's protected with a skirt, that was a commonly adopted practice. Surprisingly, we had high levels of skirt use in the control area, and this just goes to prove that's what happens when you try to do a study in the real world. So some evidence of effect in both areas. When we looked at costing for scale-up, we found that the posters and the public service announcements were really cheap, and that the motivational meetings were really expensive. So when the government saw this analysis, they said, can we do the Just Say No public service announcement, and can we do it nationally? So we said, well, we would still like to have a harm reduction, but this is a way forward. And so that last year was the first year that message went national. I also want to point out, so that on the one hand, with some primary prevention, let's reduce exposure. But another line of our thinking, we've got several lines of thinking around prevention, but one of them is around vaccine. And particularly, there's a construct vaccine based on the vesicular stomatitis virus backbone, the same backbone that was used for Ebola, has been adapted to Nipah and shown to be protective in African green monkeys. And so we are working to, you can do this, once you have the outbreak, you could vaccinate around. And within the last year, the NIH has agreed to fund the making of seed stock of this vaccine for human studies. So I would summarize by saying Nipah virus is an emerging zoonotic disease that causes recurrent outbreaks of high case fatality with person-to-person transmission and represents a global risk. It requires global support to address. If we look at the per capita gross domestic product of Bangladesh versus the USA, we have 55 times the income per person. So to say, well, let the people in Bangladesh worry about it is not a strategy for getting it addressed. So if we're serious about the global risk, this is going to require global support. I would also note that multiple levels of interventions make sense. We think it makes sense to work with people who are being directly exposed to napalm sap. I didn't talk about hospital steps, but vaccines. So there are a number of places where we feel we can intervene to reduce risk. But I also want to emphasize how many disciplines have been involved in all of this work. we didn't have government collaborators, we would not have real interventions in the field. Researchers, physicians, virologists, veterinarians, anthropologists, wildlife ecologists, behavior change experts, economists, engineers, creative communicators have all contributed. And we've also had a lot of support from law firms. Questions?
When you were thinking of the public service announcements, did you consider going through the radio as opposed to television?
Yeah, we did. We got very excited about the idea of television as being something that we could control the broadcast of, because the rural areas are by small cable operators. So we felt we could get very good spatial distinction. And we were very interested in trying, because usually when you do a mass media presentation, all you can do is a before and after evaluation. And we were trying to get, as best we could, an intervention versus not. So that's part of how we did it. I will say, if you look at some of the best efforts at mass communication, I think that they typically include radio as well. But there are a lot of people who don't have radios in rural Bangladesh either. So I think that it's pretty hard to beat the posters.
One question. I noticed that in the first case control study that you show, you choose 3 controls for every case. I have seen epidemiologists doing that, but in other studies people choose 1-to-1. What is the reason for choosing more?
Well, maximum statistical efficiency, if you have sufficient numbers, is 1 case to 1 control. So that would be maximally statistically efficient. However, in an outbreak, we only had 12 cases. So enrolling multiple controls per case improves statistical efficiency. So it gives us a little bit more statistical power. When you have what's relatively a small outbreak, it's useful to enroll more cases. Now, if you look at it's a law of diminishing returns, going much beyond 3. And it also depends if you're going to do a lot of diagnostic work, so you're going to spend a lot of money for each control. If you're dealing with an endemic disease and you've got plenty of cases, then you might just enroll similar numbers. But here, in outbreak investigations, when number of cases are small, I urge multiple controls per case, because your expenses are, you've got to get to the field, the marginal cost of enrolling a few controls is pretty small, and having statistical power is really useful.
I think you mentioned targeting men with the TB advertisements because they would be most likely to see them. But is it usually men who make the purchasing decisions in the household?
Yes. Yeah. The men overwhelmingly make the purchasing decision. So that was why we thought we needed a particular strategy to make sure we got at them. So we want to raise understanding generally, but the idea of targeting people who would make a resource decision was attractive to us.
It's a fascinating study, and your last slide emphasizes the most important part, this multidisciplinary work, which we are not trained to do and don't do very often. So to me, I think the most challenging part of that project was to develop trust with a local community. When you said you did your study in 348 villages. So how did it work? Did CDC already have this relationship? Were you able to partner with local? And then you have timing also. You only have so much time to do all those things. So can you elaborate, please?
Yeah. CDC does not have any existing relationship. And going into that number of villages is daunting. So the way we did, well, first thing I would say is we have excellent anthropologists. In my multidisciplinary research group in Bangladesh, I had more anthropologists than I had any other single discipline. And that was because they could tell me what people were saying in the community, and they could, like if you send a physician out or a veterinarian out, there's such big social distance that people fall into social roles. What am I supposed to say in this setting? And you get these, and you get very bizarre answers. I send anthropologists out, and then I call them up and say, Ms. Moon, what's going on? What have you learned? Oh, we haven't learned anything. What do you mean you haven't learned? Oh, well, building rapport. Just building rapport. So they've just been, they spent a long time, but they're trained to build rapport. And they've been in, we've had so many repeated outbreaks, unfortunately, they've actually gotten very good at talking about this and in building rapport around it. Interestingly, the pictures of the bats licking the sap that were so persuasive to the scientific community are also very persuasive to the village community. Because they're not used to seeing infrared. Oh yeah, well, okay, we have seen bats, huh? And so it is about discussion and relationship. So in that many villages, we then went with community-based local organizations. And so we connected with organizations that folks in the village connected with, and then used them as the vehicle for communication.
All right, so that's a classic Picori approach, right? So it's patient-centered engagement. What you've done is way before they develop all their guidelines for community engagement.
So I actually want to ask on the other end, so that was at the local end of community, but what about with the Ministry of Health, and if ag or others, sort of at the government, among government stakeholders and then globally, what was the persuasion campaign like to draw attention not only to Nipah as a global pandemic threat, but also the need for this kind of multidisciplinary investigation on an ongoing basis? Was it purely in investigation and then these are the outcomes, or sort of, can you talk about that?
I'd like to add something to what Spogli is asking, which is when you're working, if you have advice, when you're working with the Ministry of Health and they are against having a harm reduction message and just want to have an absolutist, don't do the X, Y, or Z behavior. Like advice with working with that in a culturally sensitive but coming from an informed perspective, what do you do in that situation? So just kind of linking that up with commenting.
I think that a lot of this all comes down to relationship. Mm-hmm. So, I mean, part of it's data, evidence is important, but an awful lot of it is relationship. And when I went there, there was a new head for the Institute of Epidemiology, Disease Control and Research. When the outbreak came, his team said, don't enroll those guys don't let those guys from ICDDRB or CDC come over. They'll take over the investigation and they'll take all the credit. So don't add with them. And so my team said, we know what's going on up there. We don't need the government. We know what to do. Let's just go up. And actually, both of us rejected the advice of our local team. My view was that you can't do outbreak investigations without the support of local government. I did reach out and said, we are offering some support. We can provide a vehicle, we can provide some diagnostics, and we went up together and we worked on it together. The other step I made is I said, no one on our team is allowed to talk to the press. And that when any questions for the outbreak comes, it goes to the government counter. And so every single time there was an outbreak, then we always gave them the best information. We really tried to help give them good information and to support them in their role. So I think that that relationship really helped. And you have to continue the conversation. This first outbreak, I was sort of torn between, but there are people making money, raising date palm sap as part of the culture. Do we really want to come out against it? The second outbreak, when we implicated raw date palm sap, I said, devastating disease, we ought to be informing people. It took, from the time that I was convinced until government was convinced, was another 2 or 3 years. But it was another outbreak and more evidence, and they said, okay. So I feel like harm reduction, long-term strategy. Right now, we were able to get them to agree to put a national message out that was professionally produced. I'm happy about that as a step forward. I consider this ongoing dialogue about harm reduction. And harm reduction, I try to use examples, but we see it in our own country. I mean, in general, people, they're very comfortable with absolutist stands. And I mean, there are plenty of examples of failures of those approach and success with harm reduction. And I think that we do have to do some advocacy around that.
So it's a long view in terms of relationship building and trust, and then over time, capitalizing, exploiting. Those sound very negative, but basically relying on those as the foundation on top of which then we build further communication around what next and how do we approach this really challenging problem.
And that's even part of the discussion with donors and with broader collaborators too, is to be able to say, wait a minute, do we care about this? All right, if we do, what's the right way forward? And so, like, having these efforts that would try and fail, and that's not going to work, that's all part of our learning process. But then at some point, well, what can we do that we can articulate what a good next step would be? And different donors want to do different pieces at different times. And I think weaving that tapestry together and still working on, I do think there's a need for scientific leadership among the team, and recognize that universities are a better place to do that than governments, because governments kind of go from one crisis to the next.
Is this campaign still ongoing? When did you implement it? What year?
So this first one was just what was the Just Say No was 2 years. The Safe SAP was 1. Okay. So I've shown you those data. Last year, 2015-16 SAP collection season, they broadcast it on Bangladesh TV. So we're getting ready to head into the next season. There's been some change in political leadership, and we're working on encouraging continued use of the instrument. We also have in place ongoing surveillance for date palm sap consumption, so we can see what the patterns of consumption are nationally over time.
And do you have data on any outbreaks or cases since you implemented this?
Well, so last year was a quieter year, but
because of the effectiveness of this, or?
We don't think so.
Okay.
We think it's natural variation. One of the things is we think that we got bumped to late night on Bangladesh public television, and we're just not sure we have any visibility. But also these are kind of spotty spillovers.
Right.
So our first hypothesis would be it was a low year.
Now, in principle, these bats secrete these virus in saliva similar to rabies.
Mm-hmm.
So there may be also a possibility that maybe a direct transmission from the bat to humans, as has been demonstrated in rabies. Is that a consideration?
Yeah. So could this be like rabies that would go saliva directly to persons? Well, one thing is that the bats aren't ill with this. This is a virus that co-evolved with them, so they're not bothered. Their immune system's not revved up by this. There are people who live under bat roosts, and if you do, you actually can smell the bat urine when you go under there. And people who live under bat roosts are at no increased risk of Nipah. We have shown this repeatedly when we've looked for it in Bangladesh, and similar findings from under Pteropus lyoli roosts in Thailand. I don't really get that because you actually can collect urine and grow virus out. It's probably a dose phenomenon or something. And we also always have to be careful, never say never, in terms of could transmission ever occur by some way. But the overwhelming pathway of transmission in Bangladesh is directly from sap. The outbreak in Malaysia it was from bats to pigs to people. So there can be other zoonotic intermediaries.
I'm curious whether there was less Nipah in the north where they were using the lime. Because I can think of chemical reasons why that lime, if it got in the sap, would both clarify the sap and activate the virus. So I'm wondering if it actually got into the sap, and that's what was preventing the disease there.
Yeah, we've done a lot of mapping now in terms of where the where the outbreaks occur, and we have and there is not a signal around using lime.
Well, great. I wanted to thank you, Steve. That was really stimulating, and I think it was a lot to think about and think about the progression of not a disease, but also a conceptualization of such a complex problem that has both cultural, physical, and zoonotic dimensions to it. So thank you so much. And for those of you who are interested, so Steve is talking again tomorrow. A much sort of larger, grander issue about the role of public health in addressing immediate threats to human extinction. So I encourage you to come to that. That's in room 144, Farber Hall. I think there's some food to appetize on at 11:30, and then the seminar's at 12. So I encourage you to come, and we look forward to seeing you. Thank you again.